So the first patient is a 61-year-old male. So this is a ascites specimen. So for the ascites specimen, when we interpret the ascites specimen, the first thing is that we need to check the gender of the patient. If the patient is a female, the most common cancer with peritonean seeding or metastasis would be the ovarian cancer. So it will show the high-grade morphology of glandular structure. And if it's a male patient, we need to think about the possibility of the GI tract. Actually, the most common cancer, GI cancer with peritonean seeding, will be the gastric cancer. However, gastric cancer is relatively not so common comparing to the most common colorectal cancer. So the colorectal cancer nowadays is ranking as the most common cancer here in Taiwan, and the first and the second place were competing between the colon cancer and the lung cancer. But the colon cancer is still among one of the most common cancer here in Taiwan. However, it is relatively uncommon to have advanced colon cancer with diffuse peritoneal spreading. Okay? So in this case, the patient actually do not have any history. He just came to our hospital for the survey of the abdominal swelling, and they find to have the ascites fluid. And in this specimen, we actually received two different specimens from the same patient. The first specimen looks relatively normal, and for this specimen, the second specimen, we only have this one cluster of cells with a glandular arrangement. The nuclear demonstrates some type of atypia, and it is very tight. So based on the morphology, it looks like to be an adenocarcinoma from a 61-year-old male. And this is probably the only cluster is most convincing for the adenocarcinoma. The other cluster are relatively indeterminate. So these has a tubular type of arrangement. The size of the nucleus is very similar to the adjacent normal cells. It has a little bit overlapping feature, but that's it. So this looks relatively bland looking. The only problem is the architectural. It's relatively three-dimensional, and that's it. However, in the cell block preparation, we do identify a few more cluster of cells with a glandular arrangement and with a traction artifact. So the nuclear atypia here is very similar to the first cluster that we see. It's quite obvious. So there were a few clusters with all these relatively irregular type of nuclear contour, and with a three-dimensional cluster and with peripheral traction artifact. So the patient received colonoscope and identify a few polyps along with also some one focus showing a feature of advanced colon cancer. So for this case, it is most likely to be the involvement of colorectal cancer in the peritoneal cavity. However, just like what I say, this is relatively unusual as the first presentation of the patient. Hence, the specimen show relatively very scant tumor cells in the cytospin preparation. The cell block seems to have more cells that we can see here. So we would do CDX2 as a lineage specific marker, as well as MOC31 as adenocarcinoma glandular marker to confirm that this is positive for adenocarcinoma. And this would be one of the first specimen in our hospital, the ascites, along with the colorectal biopsy that the result haven't come out yet. So the second specimen is also an ascites specimen. The patient went to our emergency department. He is a 72-year-old male. So in this specimen, we see some proteinaceous background material. So it's relatively unusual to see this. So additionally, we do identify a few single cells with a relatively atypical nuclear feature. So if you take a look at these cells, comparing to the adjacent cells, the nuclei is triangular, along with distinct nucleoli, and the entire nucleus is eccentric. And it seems to be there are some material within the cytoplasm of these cells. So we have a single cells with an eccentric nuclear feature, relatively similar to the signaling cells. And in the cytoplasm, we do identify some of the organophilic material, like pushing the nucleus to the one side of the cells. So this looks like a signaling cell and looks like a fully differentiated adenocarcinoma. The patient actually have history of gastric cancer, and we have signed out prior specimen as positive for gastric cancer, and the patient was currently under treatment. So here again, you can appreciate that some of the cells in the cytoplasm, you can appreciate more organophilic material. I have to say some of these cells actually looks very, very similar to a histiocyte. So these actually looks more like a so-called mucophage, that the histiocyte engulfing some mucous material, than the true signaling cell carcinoma. However, you can still identify some of the cells definitely show very atypical nuclear feature. So this specimen is still considered positive for adenocarcinoma and compatible with the patient's prior history of gastric cancer. So because the patient had a history and he is under the treatment, and we have signed out the positive specimen before, so the case is relatively easy for us. If it is the first specimen, that would be very difficult for us to determine whether these are glandular cells or histiocytes, so we might need some immunohistochemistry for confirmation. So the next specimen is coming from a 74-year-old female who had a history of advanced colon cancer, and this is her pleura effusion specimen. So this is above the diaphragm. So this is again relatively not so easy to screen, and because of this background inflammation, and also because of the cellularity is kind of scant. So I think the most convincing focus would be this one. So in the background, we do identify quite common single cell with a little bit bubbly of the cytoplasm. So these looks like histiocytes. Additionally, we can also identify a few bigger cells with a vague intercellular window. So these looks more likely to be a mesothelial cell, reactive mesothelial cell. And here, these cluster demonstrate highly irregular nuclear contour along with a very irregular chromatin pattern and arranged in a vague glandular pattern. So these looks like adenocarcinoma. So because again we have signed out the patient's prior pluripotent specimen as positive during the treatment, the cellularity might be scant of the tumor cell because it is maybe partially response. So we will have very scant tumor cell. So the history would be helped, but the bottom line is that we need to consider the cytomorphology. Again, these clusters also demonstrate a typical cell with a three-dimensional glandular feature, and this is not showing the morphology of a mesothelial cell. So this is considered also as positive. So we have a relatively uncommon specimen that we received, which is common bile duct brushing along with tumor like a tumor imprint cytology. So the first that we will take a look of the smear, which is directly from the biopsy of the bile common duct tumor. So they use the ERCP method and with the endoscope to do a couple of tissue biopsy, and along with the biopsy, they do imprint cytology. So common bile duct cancer is very similar to the pancreatic cancer that we commonly encounter in our US guided FNA. So here we do identify multiple tight cluster three-dimensional glandular cells demonstrate unequivocal nuclear atypia showing this 1 to 4 pattern and with a very irregular arrangement. So this is positive for adenocarcinoma. The smear is a little bit, the preparation is not ideal, possibly because of some pigmentation of the bile. But we can demonstrate these like a highly atypical glandular cluster, three-dimensional with unequivocal nuclear atypia. So this is considered positive for adenocarcinoma. So this is relatively benign looking common bile duct mucosa. So it shows a nice monolayer of honeycombing arrangement. So comparing to this normal mucosa, here we have the adenocarcinoma, which is showing much enlarged nucleus with prominent nucleoli. In the same cluster, you have large variation of the size of the nucleus. Here we have some mitosis. So this is not difficult for us to make diagnosis because we have these benign for mucosa for the comparison, just right adjacent to these focus. So they do two different smear from the tumor. So this one is also easy for the diagnosis. We have unequivocal nuclear atypia. We have abrupt mucin production in the cytoplasm. So this is also positive for adenocarcinoma. So along with these specimen, they also do a brushing cytology and put the brush into normal saline, like a bottle of normal saline. And so we use the fluid specimen to do the cell block along with the liquid-based cytology. So in this brushing cytology, you can appreciate in the background we do have a lot of blood clot. So this is likely that the brushing was after the biopsy. So that's why we do see a lot of blood. But also we have similar morphology of the same tumor cells that we see in the direct like imprint smear. So this is also positive for adenocarcinoma. Okay. So we rarely receive the common biotop brushing cytology because usually the yield rate is low, and because when we have a tumor of obstruction lesion, the normal biodoc will show prominent reactive changes, make it more difficult to interpret because these might show similar feature of what we will see in the endocervical smearing with a typical repair type of change, and make it relatively difficult to make a definite diagnosis of adenocarcinoma. But for this case, I think it's easy. And we have very good morphology for adenocarcinoma. So the next case is a EUS guided aspiration specimen. So these are also coming from the pancreatobiliary tract. So the morphology would be quite similar. In these cytology specimen, we identify prominent like necrotic and degenerative changes and make it a little bit difficult to interpret. So here I think most of the epithelial cluster looks nicely arranged with honeycombing pattern. So these all looks normal, but the background is a little bit abnormal because it's highly degenerated. So in this type of specimens, highly degenerated, we need to identify unequivocal cells that we can definitely call these positive, just like what we see in the prior specimen. And this specimen is particularly interesting that it demonstrates a finding that I actually rarely see, which is a stromal component with this very bizarrely arranged collagen fiber. So this is considered what we see in the histology as the desmoplastic type of stroma. So you can see that this looks like a disorganized proliferation of these stromal, like a collagen fiber. And along with these collagen fiber, you can actually identify some very tight cluster of atypical glandular cell over here. So this is representative of the tissue specimen that we see as a stromal invasion along with a desmoplastic type of stroma. Okay, so this is relatively uncommon because usually the stromal component is not very easy for we to aspirate. But for these specimen, you show these very beautiful, like a stromal, like a collagen, and along with some atypical cells. So I think for this case, it's highly likely to be an adenocarcinoma. So these is indeterminate because it still maintain a relatively honeycombing type of arrangement. The nucleus is slightly enlarged, and here is relatively like a disorganization junction honeycombing, but we don't have the 1 to 4 nuclear polymorphism. So for these cluster is kind of indeterminate. So this is also a similar cluster. This is atypical, but we can not make a very definite call just based on these morphology. So overall, I think for this specimen, we definitely see some desmoplastic type stroma along with just a single cluster of these atypical cells with a glandular feature, and it's difficult to see through because it's very thick. But this is what we have only. So if based only on these, I would say this is suspicious for adenocarcinoma. However, because we had the biopsy specimen and it has been already signed out as adenocarcinoma, so I think this is representative of a relatively well differentiated adenocarcinoma and with a stromal type of invasion pattern in our cytology specimen. Okay, so that's for all the case today.